I'm going to present a case presented with CSCR with primary open angle glaucoma. CSCR is an accumulation of fluid under retina, specifically beneath the macula, mainly affects young and middle-aged due to dysfunction of retinal pigment epithelium and increased choroidal permeability. Primary open glaucoma is a chronic, progressive, non-optic neuropathy characterized by optic nerve damage, visual field loss. Early stages are asymptomatic, but later stages show peripheral vision loss. Patient presented with black shadow in right eye since 1 month, which was painless, gradually progressive, which increases in size. He also complained of problem in vision in low light places. He was diagnosed as primary open POAG in 2021, after which patient was instilling eye drop bimatoprost with timolol in both the eyes. Similar complaint presented in right eye in 2016, for which he took some medication which was not available with records. Patient was also on antidepressant and anti-anxiety medications for last 1.5 years. On examination, the best corrected vision was 6.6 partial with correction of 0.5 cylindrical at 90 degree, and near ad was 1 diopter spherical. The NCT was normal and AT was normal. On gonio, it sclerus per in all quadrants, and perimetry shows normal with no visual field loss. On fundus examination, it shows nasal shifting of blood vessels in both the eyes, bayoneting sign was present, and NRR thinning was present. On OCT, RNFL thickness was normal, and it shows CD ratio of 0.8 in both the eyes. And on OCT macula shows CSCR. Clinical impression: CSCR was often linked with steroid use, and steroid can also cause increase in IOP elevation in underlying primary open angle glaucoma and cause worsening glaucomatous optic nerve damage. In visual field defects, CSCR causes central scotoma, and primary open angle glaucoma causes peripheral vision loss. Impact of choroidal thickness: in CSCR, it causes choroidal thickness and leakage, while in primary open angle glaucoma, it causes choroidal thinning. Take home message: patient was advised to avoid steroids and monitor IOP closely, differentiate in visual field defects, and patient was advised non-prostaglandin medication, as it can cause increase in choroidal blood flow and cause increased choroidal thickness. And for CSR, patient was advised currently he was advised for observation, and later he can be considered for photodynamic therapy.
So do you think your CSR was caused because of the bimatoprost maybe?
Sir, maybe. Because he was instilling it for way back before.
So there are case reports where bimatoprost has even caused a serous macular detachment. Usually you talk about a cystoid macular edema, but there are 2 case reports. One published in IE also, fairly recently, like 2-3 years back. So I mean, it's a known thing, yes. Very rare, but yes, I think probably it's publishable also, because I don't think that a serous macular detachment or a neurosensory detachment after bimatoprost is reported very well in the literature.